This is an AI-generated podcast based on a chapter in the book Gastroenterology Clinical Focus by Dr. Emad Qayed. We hope this podcast helps you strengthen your understanding of gastroenterology. Please like, subscribe, and share this channel with colleagues and students who might find it useful.
Welcome back to the deep dive. Today, we're jumping into some really fascinating territory.
That's right. We're sort of bridging the gap between, everyday nutrition, vitamins, minerals, and these more hidden specialized conditions like neuroendocrine neoplasms or NENs and gastrointestinal stromal tumors. We're actually seeing more GINNs being picked up, especially those small rectal ones found during colonoscopies. So understanding this classification, like Chi-67 index and histologic grades, is becoming, essential.
Right. So let's start with that foundation, how the body fuels itself, and what happens when that process breaks down. So when we think about nutrition, it's not just about what you eat. The sources really stress that certain groups are just, inherently vulnerable to deficiencies.
That's a key starting point. Patients with severe chronic diarrhea or conditions causing general malabsorption, and definitely a growing group, those who've had bariatric surgery, they're all at high risk for multiple deficiencies.
Because you're bypassing parts of the gut where absorption happens.
Exactly. You remove or bypass key absorption sites, and you just can't get those nutrients in effectively no matter the diet.
And vitamin B12 is like the poster child for complex absorption, isn't it? It needs this whole elaborate sequence involving multiple organs. Maybe we can unpack that step by step.
Let's do it. It starts right in the stomach. B12 in food is bound to protein. So first step, gastric pepsin has to cut it loose.
Okay.
Once it's free, B12 quickly latches onto something called the R factor. This is a glycoprotein from your saliva, actually.
So it needs protection from stomach acid.
Precisely. It shields it. But that shield is temporary. The complex then moves into the duodenum, the first part of the small intestine.
And here comes player number 2, the pancreas.
Right. Pancreatic proteases are needed now to break down that B12R factor complex. So if your pancreas isn't working well, chronic pancreatitis, for instance, B12 gets stuck at this step.
Assuming it gets released from the R factor, okay, then it meets intrinsic factor.
Correct. Released B12 binds to intrinsic factor, or IF, which is made by the parietal cells back in the stomach. This B12IF complex is the final package deal.
And that whole package travels quite a long way, doesn't it?
All the way down to the very end of the small intestine, the terminal ileum. That's the specific spot with receptors designed to grab onto the B12IF complex and absorb it.
Wow, so you can see all the potential failure points, stomach issues like pernicious anemia or surgery.
Yep, pancreas problems.
Or issues in the terminal ileum like Crohn's disease, or if that section's been removed surgically.
Any one of those breaks the chain, leading to B12 deficiency.
And we know that causes megaloblastic anemia. But the sources really emphasize the neurological side as the critical thing to watch for.
That's the absolute key distinction. B12 deficiency causes subacute combined degeneration. This is damage to the spinal cord, specifically the dorsal and lateral columns.
Which manifests how?
Clinically, it's a progressive loss of vibration sense and proprioception, that sense of where your limbs are in space. And biochemically, you see increased levels of methylmalonic acid.
Which brings us to the infamous folate trap.
Exactly. This is a major clinical pitfall. If you have a patient who is B12 deficient, but you mistakenly only treat them with folate.
The anemia gets better.
Yes.
Yeah.
The folate fixes the megaloblastic anemia, the blood picture looks better. But, and this is the crucial part, the folate does nothing to stop the neurological damage caused by the underlying B12 deficiency and the high methylmalonic acid.
So the anemia is masked, but the nerve damage continues, potentially becoming permanent.
Precisely. That's why you have to check B12 levels before just giving folate for megaloblastic anemia. It's a high-stakes situation. Hashtag tag 1.1, understanding vulnerability to deficiencies.
Okay, moving to another B vitamin with a really distinct syndrome, niacin, or B3. We all learned the mnemonic for pellagra, the 3Ds.
Right. Dermatitis, usually photosensitive, dementia, and diarrhea. But the causes our sources list are interesting, going beyond just poor diet.
Yeah, besides chronic malabsorption and alcoholism, what else?
Well, there are two quite specific conditions. First is Hartnup disease. This is a rare genetic disorder where you can't properly absorb tryptophan from the gut.
And tryptophan is needed to make niacin.
It's the essential precursor. No tryptophan absorption, no niacin synthesis.
And the second cause? This one seems like a perfect lead-in to our next big topic.
It really is.
Yeah.
Carcinoid syndrome.
How does a tumor cause niacin deficiency?
It's a fascinating bit of metabolic theft. Normally, your body uses tryptophan to make niacin. But in carcinoid syndrome, especially with aggressive tumors, the tumor cells are grabbing huge amounts of tryptophan and shunting it down the pathway to make serotonin instead.
So the tumor basically steals the raw materials needed for niacin.
Exactly. It diverts the tryptophan supply away from niacin production, leading to pellagra. Even if the person's dietary intake seems okay, the tumor hijacked the pathway.
That's a really powerful example of systemic effects. Okay, briefly, thiamine, B1, what are the key causes here?
Thiamine deficiency, or beriberi, is classically linked to alcoholism. Also, critically, patients on long-term total parenteral nutrition, TPN, if not supplemented properly. And again, post-bariatric surgery is a risk factor.
And the consequences are severe heart and brain.
Yes. You can see high output heart failure, a specific type of cardiomyopathy, and neurologically, Wernicke's encephalopathy confusion, abnormal eye movements, which can progress to Korsakoff syndrome, with profound, often permanent memory loss.
Switching gears to vitamin C, or scurvy, what are the telltale signs, especially GI and skin?
Classic scurvy signs point to problems with collagen. So you see inflamed bleeding gums, gingivitis, lots of tiny bruises or pinpoint bleeds called petechiae, and those really characteristic coiled hairs like little corkscrews. Wound healing is also severely impaired.
And interestingly, too much vitamin C can cause issues too.
Oh yes. High doses often lead to GI upset diarrhea, bloating. And a clinically relevant point. High vitamin C intake can cause a false negative result on stool guaiac tests for blood.
How?
Vitamin C is a reducing agent, and the guaiac test relies on an oxidation reaction. The vitamin C interferes with the test chemistry.
Good to know. Let's touch on minerals. Iron deficiency, very common cause of microcytic anemia. What physical signs might we see besides just tiredness?
Look for angular stomatitis, those painful cracks at the corners of the mouth. And koilonychia.
Which is?
Spoon nails. The nails become concave, thin, and curve inwards like a spoon.
And lastly, zinc deficiency, another one with a distinctive rash.
Very distinctive. It's an erythematous, often pustular rash, typically around orifices, mouth, anus, genitals, and on the hands and feet. Also associated with diarrhea and glossitis, which is inflammation of the tongue.
And zinc has an interesting interaction with another mineral.
Yes, a really important one. Zinc toxicity can cause copper deficiency.
How does that work? Too much zinc leads to too little copper.
It's direct competition for absorption in the gut. Zinc and copper use the same intestinal transporters. If you flood the system with high levels of zinc, like from supplements, it basically hogs all the transporters, preventing copper from being absorbed. Result: secondary copper deficiency. Something to keep in mind with zinc supplementation.
Okay, we've covered the risks of deficiency. Now let's talk about a potential danger when you try to correct severe malnutrition. Refeeding syndrome.
This is a really critical concept. It's a cluster of metabolic and clinical problems that can happen when you start feeding someone who's been severely malnourished or starved for a prolonged period.
Who's most at risk?
The risk factors include chronic alcoholism, patients with anorexia nervosa, especially if their BMI is very low, like under 16. Also, anyone who's undergone prolonged starvation or has conditions like severe Crohn's or short bowel syndrome where absorption has been minimal.
And the core problem is the rapid metabolic shift when you reintroduce nutrients, particularly carbohydrates.
Exactly. Let's break down the pathophysiology. During starvation, the body adapts. It lowers insulin levels, relies on fat and protein breakdown, uses ketones for energy. It's a catabolic state.
Then you give food, especially carbs.
Right. Suddenly, glucose floods in. This triggers a massive release of insulin. Insulin is the body's main anabolic building hormone. It flips the switch from breaking down to building up.
Telling cells to start making glycogen, fat, protein.
Precisely. And to do that building, cells need raw materials. Insulin drives a very rapid uptake of key electrolytes from the bloodstream into the cells.
Which electrolytes are we talking about?
Primarily phosphate, potassium, and magnesium. Calcium can also be affected. The cells are basically hoarding these essential components for metabolism and synthesis, leading to a sharp drop in their levels in the blood.
And hypophosphatemia, low phosphate, is often highlighted as particularly dangerous. Why phosphate?
Phosphate is absolutely fundamental. It's a core component of ATP, the body's energy currency. It's involved in almost everything. Severe, rapid hypophosphatemia can cause widespread cellular dysfunction.
Leading to what kinds of clinical problems?
Respiratory failure, muscle weakness, confusion, seizures, and critically severe cardiac problems, arrhythmias, heart failure. It can be fatal.
So preventing this requires extreme caution when starting nutrition support. What are the key management steps?
First, vitamin preloading is crucial. You must give thiamine, vitamin B1, other B vitamins, and a multivitamin before you start feeding or at the same time. Thiamine is vital for carbohydrate metabolism.
Okay, vitamins first, then what?
Go slow. Start nutritional support at a very low rate. The guideline is often around 10 kilocalories per kilogram per day initially. Then increase the rate very gradually over several days, maybe 4 to 7 days.
And monitor electrolytes like a hawk.
Constantly. Daily checks of phosphate, potassium, magnesium, and calcium are essential. You need to aggressively replace these electrolytes as their levels start to fall, anticipating the shift into the cells. It's about staying ahead of the curve.
All right, we've laid the nutritional groundwork. Now let's pivot to these specialized GI tumors, neuroendocrine neoplasms, or NENs. These aren't your typical colon cancers?
Not at all. They're a unique group. NENs arise from neuroendocrine cells, which are actually scattered throughout the lining of the entire GI tract. Their defining feature is the ability to make and secrete hormones or peptides, storing them in these little packages called dense secretory granules.
And the terminology here seems really important. Getting the classification right from the start, differentiating NET from NA.
Absolutely critical, because the prognosis and treatment are worlds apart. NET stand for neuroendocrine tumors. These are generally well differentiated. Historically, these were often called carcinoid tumors, but that term is really discouraged now because it can be confusing.
Okay, so NET is well differentiated. What's NEC?
NECs are neuroendocrine carcinomas. These are poorly differentiated and much more aggressive. A key point from the sources is that NETs and NECs are considered distinct diseases. A well-differentiated NET doesn't usually transform into a poorly differentiated NEC. They have different biology, different genetics.
Where do these typically pop up in the GI tract?
Their incidence seems to be increasing, maybe due to better detection. They usually occur in people over 50. The most common site by far is the small intestine, particularly the ileum. After that comes the rectum, then the appendix, and then the stomach. Hashtag 2.1, general concepts, classification, and diagnosis.
The grading system, based on the 2019 WHO classification, seems heavily reliant on how fast the tumor cells are dividing. What markers are used?
Two main proliferation markers are used for grading. First is the Ki-67 index. This is reported as a percentage. It reflects the fraction of tumor cells that are actively in the cell cycle, preparing to divide. Pathologists look for the hot spots in the tumor with the highest activity.
Okay, Ki-67 percentage. What's the second marker?
The mitotic count. This is a direct count of the number of cells visibly undergoing mitosis, or cell division, usually counted per square millimeter, or across 10 high-power microscope fields.
And these two numbers determine the grade, G1, G2, or G3.
Exactly. G1 is low grade. Ki-67 is less than 3%, very few mitoses. G2 is intermediate grade. Ki-67 between 3% and 20%. And G3 is high grade. Ki-67 over 20%.
What if the Ki-67 and mitotic count suggest different grades?
Crucial rule.
Yeah.
You always go with the higher grade. If Ki-67 suggests G1, but the mitotic count is high enough for G2, it's classified as G2. And remember, NECs, being purely differentiated by definition, are automatically considered high grade.
Now, symptoms. Obviously, a growing tumor can cause pain, bleeding, or blockage. But you mentioned something really striking earlier. These tumors can actually cause ischemia, cutting off blood supply. How?
It's a fascinating and damaging process involving both mechanical and chemical factors. Mechanically, these NENs, especially in the small intestine, can trigger a really dense stromal fibrosis, basically scar tissue formation, in the mesentery, the tissue that holds the intestines and contains their blood vessels.
And that scar tissue contracts and pulls things.
Yes, it can severely distort the mesentery, kinking and compressing the mesenteric blood vessels, physically blocking blood flow to segments of the bowel.
That's the mechanical part. What about the chemical attack?
This relates to the hormones they produce, particularly serotonin. High levels of serotonin produced by the tumor might directly cause vasoconstriction, narrowing the blood vessels, but there's also evidence it contributes to mesenteric vascular elastosis.
Elastosis, meaning more elastic tissue.
Yes, an abnormal thick deposition of elastic fibers within the walls of the mesenteric arteries. This makes the vessels stiff and narrow, further compromising blood flow. It's like the tumor is actively damaging its own blood supply network through scarring and chemical warfare.
That's incredible. Okay, moving to diagnosis, what about blood or urine tests, biomarkers? Is chromogranin A useful?
Chromogranin A, CGA, is often elevated. It's a protein stored in those neuroendocrine granules. However, its utility is a bit limited. It's not sensitive or specific enough to be a good screening test. Lots of other things can raise CGA levels.
Yeah, what's it used for?
Its main role is in monitoring patients who already have a diagnosed NET. You can track CGA levels over time to help assess treatment response or detect recurrence.
And for tumors suspected of making serotonin, like those small intestinal ones?
Then the test of choice is measuring 5-hydroxyindoleacetic acid, 5-HIAA, in a 24-hour urine collection. 5-HIAA is the main breakdown product of serotonin.
But there's a catch with collecting that urine sample, right?
A huge catch, very important for listeners to know. The patient must avoid foods high in serotonin and its precursor, tryptophan, for 72 hours before and during the collection. This includes things like bananas, walnuts, pineapples, avocados, plums, certain cheeses, even some cough medicines. If they don't restrict these, they'll get a falsely high 5-HIAA level.
Good practical tip. Finally, imaging. What's the best way to visualize these tumors, especially since they often have those somatostatin receptors?
That's the key. Their expression of somatostatin receptors allows for targeted imaging. We use somatostatin receptor imaging. The older method was octreoscan, using indium-labeled octreotide.
But there's a better option now.
Yes, the preferred method today is 68 gallium dotatate PET-CT, or similar PET tracers. It's significantly more sensitive and provides better resolution images than octreoscan. It's crucial for staging, finding small metastatic deposits, and determining if the tumor is suitable for treatment with somatostatin analogs.
Okay, now let's get into the real specifics, how NENs behave differently and are managed differently depending on where they arise in the GI tract. Starting at the top with gastric NNNs, or GNETs. These seem to be split into distinct types.
Yes, 4 types, and types 1 and 2 are particularly interesting because they're linked to the stomach's enterochromaffin-like cells, or ECL cells, and driven by high gastrin levels, hypergastrinemia.
Let's break down type 1 first. That's the most common one.
GNET type 1 makes up 70–80% of gastric NANs. It's almost always associated with chronic atrophic gastritis. In this condition, the stomach lining is damaged, and you lose the cells that make acid.
So low stomach acid.
Right, hypochlorhydria or achlorhydria. The body senses this lack of acid and tells the G cells in the stomach antrum to pump out massive amounts of gastrin hormone, trying to stimulate acid production.
But the acid-producing cells are gone, so the gastrin just keeps rising?
Exactly. You get chronic, severe hypergastrinemia. This high gastrin constantly stimulates the ECL cells to grow, eventually leading to multiple small NNNs, usually polyps. Thankfully, the risk of metastasis for type 1 is quite low, around 2–5%.
So if the root cause is high gastrin from the antrum, does the treatment target that?
It can. Small lesions can often just be watched or removed endoscopically. But if the tumors are growing, becoming numerous, or showing concerning features, the definitive treatment can be enterectomy, surgically removing the antrum of the stomach.
Removing the G cells stops the high gastrin, which stops stimulating the ECL cells.
Precisely. You remove the hormonal drive.
Okay, what about type 2, also driven by high gastrin?
Yes, GNET type 2, about 5% of cases, is also driven by hypergastrinemia, but the source is different. It's associated with Zollinger-Ellison syndrome, ZES, where there's a gastrin-producing tumor, a gastrinoma, usually in the pancreas or duodenum. This causes both high gastrin and high stomach acid. Type 2 is often seen as part of the MEN1 syndrome.
And the risk is higher here.
Yes. Metastasis risk is higher, maybe 10–20%. Treatment involves controlling the acid hypersecretion, usually with high-dose PPIs, and attempting to find and resect the underlying gastrinoma.
Then types 3 and 4 are different beasts entirely.
Completely different. GNET type 3, 10–15%, is sporadic, meaning it's not linked to gastrin levels. These tend to be larger solitary tumors, often more aggressive, with a much higher risk of metastasis, over 50%.
And type 4?
Type 4, 6–8%, isn't really a NET. It's a poorly differentiated neuroendocrine carcinoma, NEC, arising in the stomach. These are highly aggressive with a very poor prognosis. Metastasis risk is extremely high, 80–100%.
Okay, moving down to the duodenum. DNETs, usually small, often gastrinomas again.
Yes. Duodenal NENs are often small and solitary. Gastrinomas are the most common type here, making up 50–60%. Non-functional tumors account for about 20%.
But there's another important type found here.
Right. Somatostatinomas, about 15%. These tend to occur near the ampulla of Vater. And the key association here is that about 20–30% of duodenal somatostatinomas occur in patients with neurofibromatosis type 1, NF1.
Management depends on depth.
Yes. If they're confined to the submucosa with no lymph node involvement on imaging like EUS, endoscopic resection might be possible. Otherwise, surgical options range from local excision to potentially a Whipple procedure, pancreatoduodenectomy, if they're involving the ampulla or pancreas.
Now the big one, small intestine NEN, PSI-NENs. This is where most carcinoid syndrome comes from.
Correct. NNs are the most common NEN overall now, and their incidence is rising. They typically arise in the ileum, usually within the last 60 centimeters before the colon.
How do they usually present?
Often with vague symptoms, intermittent abdominal pain, sometimes episodes of bowel obstruction, maybe due to kinking from that mesenteric fibrosis we talked about, or even intussusception where the bowel telescopes on itself. Bleeding can occur too.
Now, you mentioned a critical point about NNs earlier regarding size and metastasis risk. Can you reiterate that? It seems really counterintuitive.
It is counterintuitive, but absolutely crucial. The sources are emphatic. For small intestine ANNs, the size of the primary tumor does not reliably predict the risk of metastasis.
So even a tiny lesion found incidentally could already have spread.
Yes. These tumors have a propensity to metastasize early to regional lymph nodes, even when the primary tumor in the bowel wall is very small, sometimes microscopic. By the time they are found, lymph node involvement is common.
Which dictates the treatment approach.
It mandates an aggressive approach. The standard treatment for any diagnosed cyanarea, regardless of its size on imaging or endoscopy, is surgical resection of the involved segment of bowel, plus a formal regional lymphadenectomy, removing the nearby lymph nodes.
No matter how small the primary looks.
No matter how small. And there's one more important surgical consideration.
What's that?
Many patients with cyanerands, especially if they have metastatic disease or carcinoid syndrome, will need long-term treatment with somatostatin analogs, like octreotide or lanreotide. These drugs are known to increase the risk of developing gallstones. So if a patient is undergoing surgery for an CYNN and is likely to need somatostatin analogs later, it's strongly recommended to perform a prophylactic cholecystectomy, gallbladder removal, at the same time as the bowel resection.
Saves them another surgery down the line if they develop gallstones from the medication. Makes sense. Okay, let's talk about the appendix. Appendiceal NENs, often found by chance.
Very often. They're actually the most common type of tumor found in the appendix, discovered in about 3 to 5 per 1,000 appendectomies performed for suspected appendicitis. They rarely cause appendicitis themselves and rarely cause carcinoid syndrome.
And the management here is all about precise size and location, isn't it? The rules seem incredibly specific.
Extremely specific, based on the ENET's 2016 guidelines. It really highlights how just a centimeter or the exact location within the appendix can drastically change the required surgery.
Okay, let's break down these cutoffs. What if the tumor is really small, say 1 centimeter or less?
If it's a 1 centimeter A&D located at the tip or the middle of the appendix, then a simple appendectomy is considered sufficient treatment.
But what if that same tiny 1 centimeter tumor is found at the base of the appendix, where it joins the cecum?
Then the recommendation changes completely. Because of the proximity to the lymphatic drainage and mesoappendix at the base, a right hemicolectomy, removal of the appendix, cecum, ascending colon, and associated lymph nodes is recommended, even for that tiny tumor.
Wow. That's a huge difference in surgery appendectomy versus major colon resection based purely on location for a 1 centimeter tumor.
It reflects the higher risk of nodal spread from tumors at the base. Now, for the intermediate size, between 1 and 2 centimeters.
What are the rules here?
A simple appendectomy is only adequate if all of the following conditions are met. It's grade 1, G1. There's no invasion into blood vessels or lymphatics, lymphovascular invasion. And the invasion into the mesoappendix, the fatty tissue supporting the appendix, is less than 3 millimeters deep.
So if any of those are unfavorable, if it's G2 or there's vascular invasion or deeper mesoappendiceal invasion,
then right hemicolectomy is necessary.
And finally, what about tumors larger than 2 centimeters?
For any appendiceal NEN, the 2 centimeters, or any tumor that's high grade, G3 or NEC, regardless of size, a right hemicolectomy is the standard treatment.
It really underscores how vital accurate pathology reporting is after an appendectomy. Okay, how about NENs in the colon, but not the rectum?
Colonic NENs, excluding the rectum, are relatively rare, maybe 8% of all GI NENs. They tend to present late. The average size of diagnosis is quite large, around 5 centimeters, and unfortunately about 30% already have metastases when found.
Which impacts prognosis.
Significantly. The 5-year survival rate is only around 50%. Treatment is typically a standard colonic resection with lymphadenectomy, similar to colon adenocarcinoma.
And finally, rectal NENs, and their discovery rate is going up because of more colonoscopies.
Definitely. Most are found incidentally during screening or diagnostic colonoscopy, and the majority are small, less than 1 centimeter.
Is there anything an endoscopist might notice during the procedure that suggests a polyp could be an NN?
Yes, a tactile clue. Typical adenomatous polyps feel soft when biopsied or manipulated. Rectal NENs often feel distinctly rubbery or firm. That texture difference should raise suspicion.
Now, unlike the small intestine, in the rectum, size does seem to matter a lot for risk.
It correlates very strongly with the metastasis risk here. For rectal innate ends 1 centimeter, the risk of spread is low, around 2%. Between 1 and 2 centimeters, it jumps significantly to 10-15%. And for tumors 2 centimeters, the risk is very high, 60-80%.
And the management strategy follows that risk stratification.
Absolutely. Small tumors 1 centimeter without any high-risk features on EUS, like deep invasion or suspicious lymph nodes, can usually be completely removed endoscopically, using techniques like EMR or ESD.
What about the 1 to 2 centimeter group?
For tumors between 1 and 2 centimeters, a careful assessment, usually involving EUS or pelvic MRI, is needed to check the depth of invasion and look for enlarged lymph nodes. If there are high-risk features, or if complete endoscopic resection isn't certain, then more radical surgery is considered. If no high-risk features, close surveillance or potentially local transanal excision might be options.
And for the large ones, 2 centimeters.
Tumors 2 centimeters generally require radical surgical resection, typically a low anterior resection, LAR, or an abdominoperitoneal resection, APR, depending on the location relative to the sphincters, to ensure adequate removal of the tumor and the surrounding lymph node basin.
Despite the high risk for larger tumors, the overall prognosis for rectal NENs is relatively good.
Yes, overall 5-year survival is quite good, often over 80%, and it approaches 100% for those small, low-risk tumors that are completely removed endoscopically. Hashtag 2.4 carcinoid syndrome and carcinoid heart disease.
Let's circle back to the systemic effects of these tumors, carcinoid syndrome. It's not super common overall, right? Affecting less than 5% of all NNN patients.
That's correct. It predominantly occurs in a specific subset. Patients with small intestine NNNs, SCI-NNNs, that have already metastasized, usually extensively, to the liver.
Why the liver metastasis requirement?
Because normally, vasoactive substances like serotonin release from an intestinal NNN drain into the portal vein and are almost entirely metabolized and inactivated by liver on the first pass. The liver protects the rest of the body.
But if the tumor is in the liver?
Then the serotonin, bradykinin, prostaglandins, and other vasoactive peptides produced by the liver metastases bypass this first-pass metabolism and dump directly into the systemic circulation via the hepatic veins,
causing the classic symptoms.
Exactly. The systemic release leads to that characteristic triad. 1, cutaneous flushing, often episodic, sometimes triggered by stress, alcohol, or certain foods. 2, diarrhea, which can be severe and watery. And 3, wheezing or bronchospasm.
And this syndrome can sometimes escalate dramatically into a carcinoid crisis.
Yes, that's a life-threatening emergency. It involves profound, prolonged flushing, rapid heart rate, tachycardia, and wild swings in blood pressure, either severe hypotension or hypertension.
How is a crisis managed?
Immediate intravenous infusion of octreotide, often starting with a bolus, then a continuous drip, along with supportive care like IV fluids. And there's a critical point here regarding blood pressure support if the patient is hypotensive.
What's that?
You absolutely must avoid using standard catecholamine vasopressors like epinephrine or norepinephrine.
Why? They're the usual go-to for shock or severe hypotension.
Because these agents can paradoxically trigger the NEN cells to release even more vasoactive substances, potentially worsening the crisis dramatically. It's a crucial pharmacological point for emergency management. You need alternative pressors if required, or rely primarily on fluids and octreotide.
Okay. And the long-term damage from this chronic systemic exposure, particularly to serotonin, can affect the heart.
Yes, that leads to carcinoid heart disease, also known as Hedinger syndrome. It develops in about half of the patients who have carcinoid syndrome.
What's the mechanism?
It's believed to be caused by the chronic effect of high circulating levels of serotonin and other substances on the heart valves and endocardium, the inner lining of the heart chambers. This leads to the deposition of fibrous plaques.
And does it affect all heart valves equally?
No, characteristically, it primarily affects the right side of the heart. The lungs effectively metabolize serotonin, protecting the left side.
So what are the typical valve problems?
The most common finding is tricuspid regurgitation. The valve leaks severely, and often pulmonary stenosis. The valve becomes narrowed. This leads to symptoms of right-sided heart failure, leg swelling, fluid retention, fatigue. Left-sided valve involvement is much less. Substances to bypass the lungs.
So an echocardiogram is essential for anyone with carcinoid syndrome.
Mandatory. It's needed for diagnosis and then for a regular follow-up to monitor the progression of valve disease, as valve replacement surgery may eventually be needed.
How do we manage the chronic symptoms of carcinoid syndrome itself?
The cornerstone of treatment is somatostatin analogs, SSAs, like injectable octreotide LAR or lanreotide autogel. These bind to somatostatin receptors on the tumor cells and inhibit the release of hormones, controlling flushing and diarrhea in many patients.
What if the diarrhea persists despite the SSAs?
For refractory diarrhea, specifically due to serotonin overproduction, there's an oral medication called telotrestat ethyl. It works by inhibiting tryptophan hydroxylase, the enzyme needed to synthesize serotonin within the tumor cells. It doesn't stop flushing, but can significantly help control debilitating diarrhea.
Okay, we've done a deep dive into NNNs, which arise from endocrine-type cells. Now let's pivot to a completely different category of GI tumor. Gastrointestinal stromal tumors, or GISTs. These are actually the most common mesenchymal tumors in the GI tract.
That origin mesenchymal is the fundamental difference. They're not from the lining epithelium or endocrine cells. GISTs are thought to arise from the interstitial cells of Cajal or ICCs.
The pacemaker cells of the gut.
Exactly. The cells that help regulate gut motility.
And where do GISTs typically show up?
The stomach is the most common location, accounting for about 60% of cases. The small intestine is next, around 30%. They can occur elsewhere in the GI tract, but less frequently.
Diagnosis can be a bit tricky initially, right? Because they grow within the wall.
Yes. If you just do a standard endoscopy, you'll see a bulge under the surface, the submucosal mass. Trying to biopsy the overlying mucosa usually doesn't get you tumor tissue, so it comes back non-diagnostic.
So how do you get a diagnosis?
Endoscopic ultrasound, EUS, is key. On EUS, GISTs typically appear as a hypoechoic dark mass that originates from the fourth sonographic layer of the GI wall, which corresponds to the muscularis propria, the main muscle layer. EUS can also guide a fine needle aspiration, FNA, or biopsy to get tissue confirmation. Hashtag tag 3.1 general concepts in pathophysiology.
The real game changer in understanding and treating GISTs came from figuring out their molecular drivers, right? What's the key genetic feature?
Absolutely. The vast majority, somewhere between 85–90% of GISTs, have specific activating mutations in one of two genes, either the c-KIT gene, most common 80% of cases, or the PDGFRA gene, platelet-derived growth factor receptor alpha.
Let's focus on c-KIT. What does that mutation actually do?
c-KIT encodes a receptor tyrosine kinase. Think of it like a receptor antenna on the cell surface. Normally it needs a specific signal, a ligand called stem cell factor, to bind to it, which then turns on the receptor's kinase activity inside the cell, telling the cell to grow and survive.
But the mutation changes that.
Yes, the activating mutations, most commonly found in exon 11 of the c-KIT gene, essentially jam the receptor in the on position. It's constantly signaling, telling the cell to divide and survive, even without the external growth signal. It's uncontrolled proliferation driven from within.
And this molecular feature directly links to how we identify these tumors in the lab.
Directly. Because the mutated c-KIT gene produces the c-KIT protein, also known as CD117, virtually all GISTs over 90% stain strongly positive for CD117 on immunohistochemistry. This is the defining diagnostic marker. Many also stain positive for CD34, around 70%.
So that staining pattern helps distinguish GISTs from other things that might look similar, like a leiomyoma, smooth muscle tumor, or a schwannoma, nerve sheath tumor.
Exactly. Those other tumors are typically CD117 negative. The CD117 positivity is really characteristic of GIST. Though, interestingly, GISTs arising in patients with neurofibromatosis type 1 are often c-KIT and PDGFRA negative, representing a different pathway. Hashtag tag 3.2 management and treatment strategies.
Okay, so the primary treatment, if possible, is surgery.
Yes, complete surgical resection is the main curative treatment.
But the surgical approach is a bit different than for, say, colon cancer or even NENs. You mentioned lymph node removal isn't standard.
Correct. GISTs very rarely spread to lymph nodes. Therefore, routine lymphadenectomy is generally not necessary. Also, unlike adenocarcinomas where you need wide margins, for GISTs, the goal is simply to achieve a negative microscopic margin, R0 resection. You don't need to take huge amounts of surrounding tissue.
How is the surgery typically done?
For gastric GISTs, especially smaller ones, a laparoscopic wedge resection, just removing the tumor with a small rim of normal stomach, is often feasible and preferred. For small bowel GISTs, usually a segmental resection is needed. Interestingly, for very small, say 2-centimeter, asymptomatic gastric GISTs found incidentally, observation or surveillance might be an option instead of immediate surgery.
But the truly revolutionary treatment came with targeted therapy, specifically imitamab. How does that work against the c-KIT mutation?
Imitamab was a landmark drug. It's a small molecule tyrosine kinase inhibitor, TKI. It works by fitting precisely into the ATP binding pocket of the mutated c-KIT and PDGFRA kinase, effectively blocking its activity. It shuts down that aberrant on signal that's driving the tumor growth.
And it's used not just for advanced disease.
Right. It's the first-line standard of care for metastatic or unresectable GIs. But crucially, it's also used as adjuvant therapy, meaning treatment after potentially curative surgery for patients whose resected GIs have high-risk features to reduce the chance of recurrence.
What constitutes high-risk features that would warrant adjuvant imatinib?
The guidelines are quite specific. The highest risk factor is tumor rupture before or during surgery. If the tumor spills, the recurrence risk is near 100%, so adjuvant therapy is mandatory. Other key high-risk features include large tumor size, 10 centimeters, or intermediate size, 5 centimeters, combined with a high mitotic rate, 5 mitoses per 50 high-power fields or per 5 millimeter sense. The FDA approval also technically covers GIs on 3 centimeters with any mutation.
So if a patient has a high-risk GS removed, how long do they typically stay on adjuvant imatinib? This seems to have evolved.
It definitely has. Early trials looked at 1 year of therapy. However, subsequent larger studies clearly showed that extending adjuvant imatinib to at least 3 years significantly improves both recurrence-free survival and overall survival compared to just 1 year.
So 3 years is now the standard recommendation for high-risk cases.
Yes, at least 3 years is the current standard. It's a long commitment, but the data supports its benefit in preventing recurrence.
What happens if, unfortunately, the GIS becomes resistant to imatinib, which can happen especially in the metastatic setting? Are there other options?
Yes, resistance is a major challenge. When imatinib stops working, the standard second-line TKI is sunitinib. If the disease progresses despite both imatinib and sunitinib, the third-line option is regorafenib. There are also newer agents being used and investigated for specific mutations or later lines of therapy. Hashtag tag 3.3 prognosis and follow-up.
Prognosis for GIS, how does it generally look?
Overall, the 5-year survival rate is around 50–65%, but it varies hugely depending on factors like tumor size, mitotic rate, location. Gastric GISTs tend to do better than small bowel GISTs, and whether complete resection was achieved.
When treating with imatinib, especially for metastatic disease, how do you assess if it's working? Is it always about the tumor shrinking on scans?
Not necessarily, and this is a really important point for interpreting scans. While some GISTs do shrink significantly, a favorable response to imatinib often manifests differently. The drug can cause the tumor cells to die off and become cystic or necrotic.
So the tumor might look different on CT, even if the size hasn't changed much.
Exactly. Radiologic criteria for response include not just a size decrease, say 10%, but also, importantly, a decrease in the tumor's density on CT scan. The tumor becomes more homogeneous and hypodense, appears darker, as the viable tumor cells are replaced by fluid or dead tissue. This change in density, even without shrinkage, is a positive sign of treatment effect.
And after surgery for a GIST, especially a high-risk one, what's the typical follow-up schedule?
Given the risk of recurrence, follow-up needs to be quite rigorous, especially for the first few years. For high-risk patients, surveillance CT scans are typically recommended every 3 to 6 months for the first 5 years, and then annually after that. Vigilance is key. Hashtag outro.
Wow, what a journey today. We've really gone from the fundamentals, like how your body painstakingly absorbs vitamin B12 using 4 different organs, all the way to the molecular targeting of GISTs based on that specific c-KIT mutation.
It really covers a huge range. We saw how critical it is to distinguish B12 deficiency from folate deficiency to avoid that neurological trap.
Right, and how for NNNs, it's just not a one-size-fits-all situation. Everything hinges on the grade, the specific location. Remembering that small intestinal NENs need aggressive surgery regardless of size, while appendiceal NEN management comes down to millimeters and precise location at the base versus the tip.
And then anchoring GIST to that CD117 positivity, the underlying KIT mutation, which directly leads to why imatinib works and why sticking with it for at least 3 years adjuvantly makes such a difference for high-risk patients.
Taking in all these specifics, electrolyte shifts and refeeding, why entrectomy works for type 1 GNETs, the dietary restrictions for a 5-HIAA test, it really gives you, the listener, a much deeper, higher resolution view of GI health.
It moves beyond just general concepts into the actual clinical decision-making details.
So as we wrap up, let's think about that connection we saw. Like how an aggressive cyanide making too much serotonin doesn't just cause diarrhea, it can actually remodel the heart valves and cause Hedinger syndrome, using the body's own hormone system against itself.
It's a powerful example of systemic impact.
Which leads to a final thought. If cancer can weaponize hormones like that, what about more subtle imbalances? Could some of those chronic, maybe lower grade nutritional deficiencies we started with, maybe subclinical thiamine or zinc issues or borderline B12, be contributing to ongoing, unexplained chronic GI symptoms, even if there's no obvious tumor yet? Are there pre-disease states driven by these micro-level imbalances?
That's really the frontier, isn't it? Where that deep understanding of basic nutrition and metabolism meets clinical intuition about subtle dysfunctions that might precede overt disease. It's about connecting those dots early on.
Definitely something to think about. Thank you for joining us for this deep dive. We hope this detailed exploration equips you with valuable insights.